In his new book, The 60% Solution, Rethinking Healthcare, author Todd Furniss breaks down healthcare problems and solutions to free the industry to do its job. There are 5 major constraints: poor use of primary care, inconsistent accounting and incompatible IT, hidden pricing, restricted health savings accounts, and hyperregulation.
Welcome to today's Thursday brief. We're actually getting this out on Thursday, so I'm pleased about that. As always, if you like these videos, please share, like, and subscribe, or like, share, and subscribe based on the order you want to pursue. But I really appreciate your support. I'm pleased to report now at this point, we're over 240,000 views of my podcast, and I think that's really a formidable number, and hopefully we'll continue to garner support across the viewership, or the audience, if you will, that are interested in the topic and the topics that we're discussing. Today is going to be a little bit of a preview of some of the things I'm worried about, or some of these things I'm thinking about that are going to affect the industry. Yesterday, I had Leon Wisniewski on the podcast, and we talked a lot about price transparency in conjunction with the Price Transparency Act that was put in place on January 1st of this year. And he pointed out a number of issues that exist with regard to hospitals performing their legal obligations to put prices out on the web in machine readable format, so that people can do price comparisons and the like. What we had covered yesterday was the fact that many hospitals are either not complying at all, or they're intentionally obfuscating or are making even more opaque their prices, because they don't want to engage in the marketplace, and they don't want to have price transparency for a whole bunch of reasons. None of that's good, and none of it's good because it's not what the country was based on, which is the issue of competition, and it runs against the empowerment of the consumer, which was what we desperately need in healthcare. We don't have a consumer-based model. We have a model where somebody pays somebody to pay for their healthcare, or somebody pays somebody to pay somebody to pay somebody to pay for their healthcare. And it doesn't. The model is broken, and we're seeing that expressed in terms of high overhead costs, lots of fraud, waste, and abuse, and high prices. So we unpacked that quite a bit with Leon. We also unpacked this last week with Bill Hennessy of Prater. And one of the things that I was asked this morning from a friend of mine is, what's driving the rapid increase in the number of people viewing the podcast? And I think one of the issues is the fact that people are very concerned about price transparency and the marketplace. The marketplace is not free and open. And I pointed out in an earlier episode what's going on with United not letting new physicians into their network in certain areas, reducing the payments that they're making to in-network physicians, and then lastly, hiring a bunch of physicians or buying physician practices so that they're employing physicians directly. That seems like an anti-competitive behavior, and so that leads us to an upcoming guest in the form of Junior Senator Steve Daines, who is the sponsor of an act called KIRA that was passed last year. I'm looking forward to talking about that in an upcoming episode, because that's going to be talking about the Competitive Health Insurance Reform Act. And one of the things it does is it removes the exemption of health insurance companies from antitrust violation allegations. So that'll be a fascinating conversation. But in addition to that, there's some other issues brewing in the marketplace that are increasingly nettlesome. I mentioned the issue with insurance companies buying physician practices. What I didn't mention yet, and I'm going to mention now, is that a study was released that was highlighted in Becker's earlier this week that said that now over 50% of all physicians in the United States are employed, meaning that they work for hospitals. And that raises a whole nother set of issues, because now what the hospitals are trying to do is they're trying to control And there's a lot of economic support for the rationale to do this, but they want to control not only the protocols and the physicians, but they also want to make certain that the prices that are charged to the insurance companies are blended to the extent possible. And it's a take one, take all kind of a deal, meaning that the insurance companies are limited in their real negotiating power with large hospital systems who control most of the markets in which they operate. And therefore, the hospital systems can come back and say, hey, you have to take every physician, and we're not going to make distinctions based on price or quality. That's not helpful for a market to function correctly. And if you look at every major metropolitan area in the United States, they're dominated by 1, 2, 3, or 4, and very, very seldom is it more than 4 hospital systems. In Dallas, for example, where we are today, there are 4 hospital systems that dominate 98% of the market here: Baylor, HCA, THR, and Methodist. If you take Methodist out, the top 3 hospital systems control about 91% of the market. So this is clearly an oligopoly. And so the insurance companies can't really easily come in and say, hey, I'm going to go with a bunch of independents and create an independent network that excludes any of those hospital systems, because they won't have the ubiquity of coverage that they need to serve their customers or their patients, the clients, if you will. So what we're seeing, what I'm really driving towards, is we've got kind of the twin titans forming. On the one hand, we have the payers increasing their power and economic strength and informing and influencing what's going on, and then now moving into a vertically integrated model that includes physician groups that they're buying. And on the other side, we have hospital systems growing and becoming more powerful and establishing a more comprehensive coverage area for the markets they're serving, and using that in terms of their negotiating power with the insurance companies. And then the other thing we have going, which is somewhat problematic, as we pointed out yesterday and last week, is that the insurance companies increasingly have service components to them, which include third-party administration functions and other functions that create a greater deal of ambivalence towards the price being paid for the services being rendered. So that's not helpful either. So we see, just to regroup, we see pricing already legally moving towards greater transparency, functionally and pragmatically not moving very quickly, and some hospital systems outright thumbing their nose at the law. We have hospital systems who are now employing more physicians, controlling the network of referrals, and driving more business to the exclusion of others. And then we have insurance companies that are also vertically integrating, hiring physicians, buying physician groups, and then limiting who can be in their network. And so all this operates to the detriment of the consumer and the detriment of the patient. We don't, as I mentioned earlier, have a truly free market, and that's compromising the ability of lots of people in the marketplace to get care or to get affordable care. So get care at all or get affordable care in a place that's reasonably accessible to them, meaning proximate. These are issues that we think we feel less acutely in major urban areas than we might experience if we were in a less populous area. But one of the things we pointed out in our healthcare inequality index is that there are hundreds of acutely underserved markets with populations of between 150,000 and 300,000 people each. So these are not tiny markets. These are secondary or tertiary cities that are underserved. And that means that there are people who have the money to buy the services, but there are not enough services to buy. That's a problem. It's a problem also if you have services to buy, but nobody can afford them. So that's just another side of the coin. So we have to, the goal should be to have a market where healthcare services are readily available and cost effective to purchase, meaning more people can afford to buy them. Healthcare ought to be something that we can all engage in that we can take on proactively, that we can take our own measures to work on things preventatively, but it ought not to ever be so expensive as to be unaffordable. And market forces ought to be employed and ought to be vibrant in a way that drives price and cost down. We haven't been seeing that dynamic in the marketplace for a long time now, and we're paying on the price, no pun intended for it, not only in terms of the price we pay when we get to the service provider, but also the price we pay in terms of insurance and in taxes. So it's hitting us in many, many places. I'm looking forward to upcoming conversations about all these topics, and it'll be a fun exercise. The other thing to note is I'm really pleased to say that I have had 2 conversations, and just in the last couple of days, with people who said, hey, you know what, Todd, I read your book. And as a result of that, I employed some of the tools you gave us in the book to go negotiate price with my service provider. And as a result of that, I paid a substantially lower price for the services I got, as opposed to the ones they wanted to charge me otherwise. So I'm grateful that people are actually taking the work that we've done in the book and taking the tools and saying, hey, I can go do this myself, and then getting better prices than they would have otherwise reached on their own or without negotiating. So with that, I want to leave you with a happy message of hope and opportunity, because we've laid out the framework for how to go about this in the book, The 60% Solution, Rethinking Healthcare, which unabashedly promoting our self-promotional is available on Amazon and also at toddfurniss.com. But I want to just say thank you once again to everybody for supporting these podcasts, and I'll look forward to talking to you next week. Thank you so much.